Hi, everybody. Good afternoon. We're going to get started here. So I'm really excited to be here and be a part of IEPA. It's always a really wonderful conference. And I think you guys know that we're going to be talking about supported education and fidelity and the IPS model. And our first speaker, who I don't really think needs an introduction at all, but is Owen Kalaki. And Owen is the head of the Functional Recovery Research at the National Centre of Excellence in Youth Mental Health in Melbourne, Australia.
Thanks, Lana, and thanks, everybody. I'm glad there's enough room in this room for us all. But yeah, maybe we should squeeze up to make room for the others who are no doubt coming in. This is a talk, I've called this Starting Fires, Not Filling Buckets, because it's basically stealing this quote from Yeats, which is that education is not the filling of a bucket, but the lighting of a fire. But because this is about education, you know, and I'm always wanting to be right in my educational stuff, of course, this quote isn't from Yeats at all. It's from Socrates. But it turns out it's actually not from Socrates either. It's actually from Plutarch. But the point, I guess, is that education is a really important thing, and we need to actually be focusing on it quite a bit. So why is it so important in psychosis? We know that psychosis is quite costly in a whole range of ways, but particularly in these three ways: personally, economically, and societally. And I'm not going to dwell too much on each of these, but if you look at the personal stuff, you know, people with psychosis are disproportionately single. These are data from a study called the SHIP study, which was a survey of people, like a nationally representative survey of people with psychosis in Australia. So disproportionately single, disproportionately socially isolated, and I've always been particularly affected, I think, by that figure of 13% of people with psychosis having no friends at all. And I can only imagine, on top of everything else, of having an illness, how toxic it must be to actually have nobody to talk to. And disproportionately homeless. From origin, so contractually obliged to show this in every talk we do. It's societally very expensive too, and the reason is obviously, you know, the onset is here around this sort of adolescence, early adulthood, but the disability, which is this lower pink colour, rises and stays very constant across the life, and it's not that it magically gets better when people get into their 60s. Of course, it's because people are dying a lot earlier than they should. And the societal cost of all that is that we miss out on all the contributions that people might have made, because at the most productive part of their life, and the part of their life where they could give the most back, their contribution is not able to be made. And economically, we don't need to dwell on this too much. It's very expensive. And you see in that last column that a significant percentage of GDP across different studies, I mean, these are all estimates, and that's I guess the nature of economics, but pretty much these are all high-income countries, but if you look at it, it's a very expensive thing, and the picture's not dissimilar in low and middle-income countries either. Part of the reason why it's so expensive is if you look at the proportion of people across different countries who end up on disability benefits. These are OECD data, but you can see that they're strikingly similar across a range of countries. And I don't know this for all of these countries, but definitely in Australia, if you look at the people on our disability support pension who are under 35, 50% of those, their primary disabilities is a mental health issue. So this is a huge and costly problem. So one of the things that people did, obviously, to deal with this was they developed these employment interventions, and these are the three key ones, but again, in the interest of time, I'm not going to talk about social firms or transitional employment. And obviously, In terms of supported employment, individual placement and support is the most researched and most evidenced supported form of supported employment. And I'm going to take it that most of the people in the room are aware of the sort of 8 principles, and I won't spend too much time going through those. If you want to read more about it and you haven't already read this book, this is a very good book to read, and you can get it, I think, from Amazon, as you can get everything else. This is Gary Bond's slide, which he keeps updated very helpfully, and basically showing that no matter what it's been compared to, wherever it's been compared to things, IPS has tended to outperform significantly whatever the other available employment opportunities were for people with mental illness around the world. And I think the around the world thing is quite important because it shows the robustness of the intervention in different places. But when you look at it, education wasn't central to that from the outset, and I think there's a few reasons for that. The first one, of course, is it's a form of supported employment, so the clue is kind of in the name. And so there's one obvious thing. The other thing is I don't think government drivers, which is what pushes a lot of this stuff, encourage educational outcomes very much. You know, the government's incentive is to reduce the cost of welfare, and the best way to do that is obviously to help people transition into work. If you were being really cold about it, in the short term, education's actually another cost, so there's actually not a lot of incentive to do that. I think too that the early intervention paradigm was kind of only in its own infancy when supported employment was being developed, and the focus, particularly in a lot of those early studies, tended to be on older cohorts of people, and I suspect that the issue was about just reconnecting them with jobs that they could get into. There is another reason, and I haven't put it there, and I've often wondered about this over the years. It's the degree to which, as a field, we have perhaps perpetuated a stigma in a sense, because if you take education as being the foundation of successful career, I find it interesting that as a field we haven't particularly focused on this very much, and I wonder to what degree, you know, I don't think we've had a meeting and decided on this by consensus, but to what degree have we also bought into that idea that we don't need to prepare people for careers because they have a mental illness? So IPS began to be used in first episode psychosis. This is a slide of Miles Rinaldi. And one of the striking differences between this and the earlier slide I showed, of course, is that education, which is the red part in those bars, began to be measured, because when you start to work with people who, many of whom are only 15, the issue isn't about what job you can get them into, it's about making sure that they actually finish high school or its equivalent. So as we stretched IPS into that area of work, education became more important. This is another slide of Miles's, and I'd like to sort of remember Miles very much, even though he's not at this meeting, he couldn't be here. But this is, and I've said this before, one of my most favourite slides in the whole of IPS stuff, because this is from one of the early studies that they did. And you can see at the start, all the people in that study who are in mainstream education, and over the 2 years, obviously that blue bar decreases, but it decreases because people finished the qualification they were doing and they transitioned into employment by and large. And that's exactly what you would want to see happen. That's exactly what you want to see happen, which is why I think this is one of the most hopeful slides that there is. A few quick statistics. And Luana, if you could keep, because the clock's not running up here, so otherwise I'm just going to talk all afternoon. Left? Whew, I better hurry up. Obviously, it's bad to have a mental illness when you're trying to finish your education. You're much more likely to not finish it, and you're much more likely to make a poor transition to employment at that point. And I think traditionally it's not been seen as the business of mental health services. So here's 2 reasons why we should focus on education. So the first one is that ambitions to learn and to work and to have a career haven't been diminished. So this is some data from our stuff. So oh no, this isn't our stuff at all, sorry, I'm lying. This is from other studies, basically showing that employment and education, I think Kim Muser talked about this the other day, are highly desired outcomes for people across a range of studies. We know too that for a young person, change is the only certainty. This is the sort of projection, and that people in their lives will have 17 jobs across 5 careers. And when we look at the young people who were in one of our studies, this is the data I thought I was getting up to before, this is what they were doing when they came into IPS or before they came into IPS. And these are just classifications of work on that side. But when you ask them where did they actually want to go, you can see that where they wanted to go was very different from where they were. So after 6 months of IPS, that's where they started, where they wanted to go, and where we had managed to get people. So there's a bit of a move through that. But the good thing about the stuff, if we add the yellow lines is the educational courses that they were connected with, and where those courses might lead. So you can see that the education is taking people closer to where their career ambitions actually were, and a whole range of things from short courses through to university degrees. So the second thing, of course, is that education protects, and we know that if you've got more education, you're likely to earn more money, and you're less likely to be unemployed, and that's pretty true across, as far as I know, the whole developed world. One of the things, though, that we need to protect people from over time is the increasing automation of jobs. And this is some data from a place called the Foundation for Young Australians, sort of suggesting that over the next sort of 10 years, up to 70% of the entry-level jobs that young people tend to go into are going to be affected by automation. And you see this already. Like if you go across the road to the supermarket, most of the checkouts are automated checkouts. And 5 years ago, that wouldn't have been the case. So supermarkets need to employ less people to do that job, and the same with airports and everywhere else. So a lot of those entry-level jobs are going, and that means it's even more important for young people to get good education so that they can actually enter and compete in the workforce that will be there. So is IPS doing a good job with that? Well, this is, it's always good not to dob in other people's studies. So this is data from our own stuff, and you can see that there's no significant difference in terms of outcome for the education stuff. And that could be because we're really bad at doing this in Melbourne, but luckily, saved by Gary Bund again, it turns out that all of us who are doing IPS in first episode psychosis could be doing a better job in terms of the educational outcomes. And the quote there, of course, is that IPS increases employment rates, but not the rates of enrolment in education. One reason for that, I think, is that potentially IPS and the IPS fidelity scale is directed towards employment, as we discussed at the start. So how would we remediate that? One of the things we could do is start by adapting the principles of IPS so it has a bit more of a focus on education. That we could focus on enrolment in a community educational training course, and I think that's important, that we're not putting people in set-aside stuff. This is about connecting people into the communities that they're part of. That we would follow that principle that it's open to any person with a mental illness who wants to reconnect with their education, or indeed wants extra support to remain in their education. That's the other thing to remember. There's a lot of people who are precariously in their education when they come to us, and it's important we maintain that for them. Get on with getting into it as quickly as you can. It's a little bit different with education often because there are particular times of the year when enrolments happen. So in some ways, it may not be possible to get onto that straight away, but getting ready for it and getting things lined up for it could be possibly quite good. Integrated with the treatment team, help people do the courses that they want to do in line with their goals, long support, and obviously, as you do with the employment, making good relationships with the local education providers. And in some ways, education's a more tricky sector because there's so many different levels of it. So having those good relationships with providers is really important. So what to do next? Well, this is a screenshot. It's not a video. It's a screenshot from the IFever meeting in Tokyo 2 years ago. And one of the things that came out of that day was a commitment that we would look at creating an IPS education fidelity scale to sit alongside the IPS fidelity scale. And I'm not going to talk about that because that's the subject of the rest of the symposium. But that's what we would do next. So to conclude, obviously getting psychosis impacts people's educational attainment, and that has a flow-on effect to the rest of their career. There's some really interesting data from the Dunedin longitudinal study that basically shows that having any experience of mental illness as an adolescent has a deleterious and negative impact on your vocational functioning at age 30. So if you have a serious and ongoing illness, that's going to have an even bigger impact. One of the other things, I guess, to sort of comment about is how developmentally normal it is that young people should be involved in education. And it's increasingly necessary in order for them to retain or remain competitive for those entry-level positions as we saw over time. It's not just those entry-level positions too, by the way. My wife's a lawyer, and the other thing that report said is that one of the occupations most likely to be subject to automation is law, which makes a lot of sense because you think 90% of its contracts, which are if this, then that. It's pretty simple to do that and it'd be a lot cheaper. We need to do better around the educational outcomes to do with IPS, and it's possible that we might be able to do that by having a fidelity scale that forces us to focus on the things that we could be doing around education and ensures that we're doing them better than we obviously have been in the past. There's actually no reason for this picture. I just wanted it to be in the presentation, but I'm sort of finished now, and if people want to contact me, there's my contact details. We're going to do some questions. Yeah.
Hi, Owen, thank you. Would IPS for education be done by IPS workers who are also doing employment work, or would it be done by a separate group of people who built networks in an educational world?
This is a really good question, and it's not something that's fully resolved. To the best of my knowledge, there's 2 little studies which have looked at IPS for education in isolation, so just focusing on education. Both of them were done in Australia. We did one, and some colleagues in New South Wales did the other one. And what they did in those studies was got a worker who had an educational background. The simple way of saying that is a teacher, which is what those people were. And they had this expert knowledge around the education system, not surprisingly. Those 2 studies, they were both very small, uncontrolled studies. Ours had 19, the other one had 20 people in it. But the outcomes were very positive. Is that a feasible thing to do in a small environment where maybe IPS is not well resourced? Well, it's probably not, because then you have an extra person. So the issue would be ensuring that somebody, perhaps who has employment skills, can be upskilled themselves around the knowledge of the education system. But I think, Venka's got probably much more experience about that from, Job Recept and School Recept in Stavanger, so you probably talk about that as well.
I will talk a little bit about that in my talk, yes.
Thank you.
Yep.
Oh, here you go.
Okay, I'm coming from the data we have from Raise Navigate. You had the slide from Ramsey, people's interest in school.
Yep.
Ramsey Morgan in the middle slide. The Ramsey one was the highest one, and there they asked people, are you interested in going to school, and I don't know, work or school in the coming years, and it's not as high as we think it is, and people who are long-term more psychiatrically ill, where we say 80 or 90% in theory want to go to work in school. I don't know if that's true. Can you comment about the desire to go back to work or school, because I'm not persuaded that it's as high as we sometimes think.
I think it's a really interesting thing. I think At the outset, I think it is reasonably high, and I think it's high because people want to be doing what their peers are doing, and they're still not always disconnected from those peer groups. So I think there's an element of positive peer pressure. I've always been interested to the degree to which self-stigma begins to affect people's choices and ambitions about what they do, and I think over time that probably eats away more at that desire. It's interesting too, the systemic things that are around that as well. I know in many places that if you want to access particular benefits, welfare benefits of one sort or another, it almost requires you to give up on pursuing some of those goals as well. So there's those things. The other thing, in the education study we did, we had no problem. We got, 20 was our capacity, so we got those 19 people very, very easily. But because the funding came from our state education department, we could only work with the 15 to 20-year-olds because they don't fund over 20. So I've always been interested, if you could extend that across our entire age range, would you actually more easily get people, because they're beginning to realise the cost of not having completed their education. Whereas if you're 16 or 17 and you're not going to school, you may actually not be that bothered by that. So it's probably about a thing about where you are in your life when this happens as well. What I find interesting, no matter how high the actual absolute level of those things is that the order of those things across studies is fairly consistent. It's a bit variable in the actual numbers, but the order is relatively consistent. And I find it fascinating that in most of those studies, symptoms always seems to come about fifth. And it comes, after employment, education, relationships and housing. And as a person interested in functional recovery, give or take a bit on the numbers, I'm very persuaded that there's a great demand for this stuff. And I'm going to have to apologise because I've got to go to another symposium right now, but thank you.
Thank you, Owen, for that, excuse me, for that talk. It was really wonderful and a nice segue into the rest of our speakers. So our next speaker is Jaap van Wegel, and he's from the Center for Excellence in Utrecht in the Netherlands.
Thank you, Luana. Good afternoon. Owen already told us so eloquently that educational attainment is critical for the personal growth of people, for young people especially, and also for obtaining meaningful jobs and developing social and occupational networks. And we all know that a first episode of psychosis often disrupts academic work, contributing to poor performance and high dropout rates from school, college and universities. And with the development of first episode psychosis programs, IPS services have increasingly included supported education. So I will talk from a Dutch perspective from the Netherlands. And this slide you know already, Owen showed this. I think all these principles of IPS pertaining to employment are already quite familiar. And this slide looks familiar to the one Owen already showed you, but this one outnumbers the one Owen showed us, because this is the famous graphic of Gary Bond. And these are with 22 randomized controlled trials with positive results on IPS. And I've been told that we have already 25 studies also, all positive for IPS. So it's constantly changing. And one of those studies was conducted in the Netherlands, and it was published 2 years ago. And luckily we found also positive results on the employment side of IPS. We did a 30 months follow-up study, and the IPS group, in the IPS group, 44% of people with severe mental illness, not with early psychosis, but severe mental illness, got jobs, and 25% of the people in the control condition. So we were very happy to have that. But we had to move on with IPS in the Netherlands, so we formulated some future directions, some challenges. For instance, serving many more clients with severe mental illness and early psychosis into IPS practices, tackling stigma issues, very important in employment and education, attain surplus value by introducing peer specialists in IPS practices, attain surplus value by engaging personal resource groups, families, for instance, in IPS practices, to have add-on interventions to enhance IPS, like cognitive enhancement. Corel is about concealing or revealing your psychiatric condition, RAP, etc. And of course, very important to establish a stable and adequate financing of IPS, which is a great problem all over the place, I think. And last but not least, and this is the topic of today, to develop and implement an effective methodology for the education part of IPS. So this is the emerging practice also in Holland, IPS for people with early psychosis. And the reasons to offer IPS to this group, and already Owen told us something about, is that young people are open and eager to new experiences and to learning new roles and skills. And the potential benefits in terms of career symptoms and social inclusion are substantial. And the outcomes of early practices of IPS with young people with psychosis are promising. So it is essential to add education as the second valid outcome measure to IPS programs for these young people. And also to develop a fidelity measure which is appropriate to the education part of IPS. So we need a lot of adaptations to IPS for early intervention practices. Keith Nuchterlein and Luana Turner told us much about this in their articles. I won't go into that because I think you will tell us about that. But you need some adaptations for these practices for young people. This systematic review already was shown by Owen, and 28 studies and incorporating supported employment services into early intervention programs. Well, it increases indeed employment rates, but does not improve educational outcomes. And these poor outcomes can be partly explained by a lack of focus on the educational dimension of IPS. And this is reflected in the current IPS fidelity scale that only addresses employment supports. So these are our objectives: first to develop a complementary supported education scale for IPS practices serving persons with early psychosis, and to integrate this scale entailing education supports with the existing fidelity scale from Dartmouth University addressing employment supports. And in the Netherlands this was done in the context of a multi-site RCT on IPS plus cognitive remediation. But first of all, some general remarks about fidelity assessments, the rationale behind this. Fidelity assessments have administrative, practical, as well as research purposes. For example, you can determine how adequately a program model has been implemented. And you can assess conformity with prescribed elements and the absence of non-prescribed elements. Or to provide assurances to policymakers that services are being implemented as intended and are reaching the target audience. And in non-research context, fidelity may be simply defined as the adherence of actual treatment delivery to the protocol originally developed. So this is behind all our efforts to make this scale. This was the context, a study design named CREW, Cognitive Remediation and Work. I won't go deeply into that because it's just the context. But we are still in the process of conducting that RCT on cognitive remediation as an add-on to IPS practices. These are the organizations who collaborated in our study, 9 in total. And they were all in this IPS breakthrough project for early intervention of psychosis in the Netherlands. It's a large network, and all kinds of new elements and new interventions were tried out there among others IPS with education. So developing an IPS education fidelity scale, how did we do that? As a starting point, we took the supported employment fidelity scale from Dartmouth, from Gary Bond, Debbie Becker, and Bob Drake. And we studied the literature on supported education and IPS model fidelity. We consulted Dutch experts on this subject. We did a focus group of IPS practitioners and IPS trainers to learn some more from them. And as I already told you, in our multi-site RCT on IPS practices in 9 early intervention teams, each serving 100 to 250 clients, the IPS supported education claim was administered at baseline last year, 2015, and at 1 year follow-up. Most of these teams, I have to tell you this, just started with implementing and practicing IPS. They were really new in the field, most of them. And IPS trainers and practitioners were also interviewed afterwards, after we conducted the scale, discussing validity and feasibility of the scale. And you have to bear in mind that our study is work in progress. Not all the data are gathered or analyzed yet, so it's incomplete. The original IPS fidelity scale on employment, it contains 3 sections: staffing, organization, and support. And it contains in total 26 items. And we changed them into 9 items having the same score for IPS employment and IPS education, 8 items with different scores for IPS employment and IPS education, and 9 items having different phrasing for IPS employment and IPS education. Well, what does it look like? Staffing, for instance, you can see here the items on the left side. I hope it works. And you see here scores for employment and education. And you can see on the right side whether different scores are possible for those 2 dimensions or not. And the same goes for organization, the organization section with 8 questions. And one of the questions is an example here. And you can see here that it's about the collaboration between IPS workers and vocational or educational rehabilitation counselors. This collaboration will be quite different from employment in the education practice, I think. So that's just one example how we had to adapt phrasing. This is the support section of the supported education part of IPS. And you see the same pattern as in the slides before. And this is one of the items with a single rating for IPS employment and IPS education. Integration with the mental health treatment team. You should do it with employment and you should do for education the same score. This is also an example of one of the items, individualized follow-along supports. And you can see that, for instance, the financial aid and other income needs, they are quite different in the educational practice as in the employment part. And we also have some items with separate ratings for IPS employment and IPS education. And this is one of the examples. I don't expect you to read all this, it's much too small. So what are the results after those 2 assessments in 2015 and 2016? We have data of 7 teams, not the all 9, but 7. And you can see here that IPS employment and IPS education are pretty similar in their results over the 2 years, and not much progress in those years. They had difficulties having things in place and having their trajectories financed, their practices financed. And you can also see that, well, you have only good fidelity when you have a score 100 or more. And we did not reach that in those practices. It's all fair fidelity, moderate fidelity. Starting teams, they are just starting. So there is much room for improvement, you might say. And I can show you how it was for the different teams, the 7 different early intervention teams for the year of 2016. And you can see here that two teams reached good fidelity on the employment part, this one and this one, and all the others did not. And in the educational part of the practice, none of the teams reached good fidelity. So that is still a lot of opportunity to improve your practice. And what were the items with the lowest rating? Because that is then important. What they find very difficult? Well, in the organization section, for instance, having an IPS employment or IPS education unit in place in your organization, 6 out of 7 teams did not have that in place. The role of the IPS supervisor, this is a very questionable item in the Dutch practice, because the whole notion of supervisor is becoming obsolete. All our teams are becoming self-steering and self-organizing, so this is an item we should reformulate, I think. IPS support from agency leadership was also a problem, and the focus on regular employment and education, 3 out of 7 teams had serious difficulties attaining that. And in the support section, conducting ongoing vocational assessment and ongoing educational assessment was a problem. The development of jobs and the development of educational placements, 4 out of 7 teams had serious difficulties in implementing that. And the same goes for 3 teams who are having difficulties to have really community-based service to operate in the community and not in your office. So here is a slide. We don't know much about IPS fidelity and its relationship with outcome, with client outcomes in terms of employment and education. And I only have some anecdotal data on this. You can see here on the blue part that I selected 3 teams, Team A, B, and C. Team A was taken from outside, was not part of the crew study. But I selected this one because this one was with a high fidelity, with a good fidelity. 111 on the employment part and 106 on the fidelity part. And you can see from the numbers of placements, both on the employment part and in the regular education part, it suggests that there is some relationship between good fidelity and better outcomes. But we don't know that for sure. You need much more power in your study to answer that question properly. So what were the experiences of IPS workers and IPS trainers with this practice and with this new scale? Well, first of all, they had a positive attitude towards and also positive experiences with the implementation of IPS education fidelity scale. They said that attaining educational goals, they found it harder than attaining employment goals. And they needed special expertise, more special expertise regarding educational opportunities to attain high fidelity IPS on the education side. So they have a lack of expertise. That's what they were. That's their experience. So we need at last, I think, 1 educational specialist in our IPS team. That's what they said to me, agency-wide. Perhaps 2, but 1 at least. And we need educational support being better financed. Up till now, it was very, very difficult to have it financed in the Netherlands. And they also said the outcome measure, days in regular education, is similar to days in regular employment, is very questionable in this context, because you can be in days in regular education and not being very active in that education. So it doesn't say much. So these are my preliminary conclusions. Administering the IPS education scale seems feasible in our country. No early intervention psychosis team attained good fidelity on IPS education. 2 teams did on the employment part. Only small differences were found in the total scores of IPS employment and IPS education. However, IPS workers experience a lack of expertise regarding education and find practicing IPS education more difficult than IPS employment. And that's logical because most of them are trained as employment specialists. So, content validity of IPS fidelity scale still needs to be discussed. And the predictive validity, its relationship with client outcomes on education, is still unknown. And IPS teams in mental health agencies should have at least 1 IPS worker specialized in education. And we should pay more attention to educational expertise, for instance, cognitive enhancement, study skills, etc., in recruiting and training our IPS workers in the Netherlands. Thank you for your attention.
Okay. Oh, thank you, Jaap.
Okay.
Thank you, Jaap, very much. It's wonderful that as we were developing the scale, which I'll talk a little more about at the end, you were able to get your teams up and running and trying this out. So it's wonderful. And I think it's going to be nice to see what we show down the road. Thank you, Jaap. So our next speaker is Venki Tenvelden, and she's a clinical and research psychologist. It's also important to note that she's half Dutch. And she's from the TIPS group in Norway.
Thanks so much. I'm impressed that so many people showed up. This is the graveyard slot. My friend Lucia is in the other room, and we were worried about attendance, and I'm impressed. Thank you all for coming. So I'm not going to do much theoretical work here today. Yes, my slides are up. I'd like to give quite a practical talk to tell the story about our project Job Prescription evolving into school prescription and integrating the two. Next, please. Oh, I can do it myself? Okay. First of all, of course, the acknowledgements. We're funded by the Norwegian Extra Stiftelsen, which is a non-profit government regulated fund for research and innovation in healthcare, and we're also funded by the Norwegian health authorities. There's no conflict of interest. Some abbreviations that we use: SE, supported employment; SED, or SED, supported education. The scale that we've been working on for 2 years now, adapting, and that Jaap has just shown you some slides of, is called the Adapted IPS Fidelity Scale. And I'm also with the TIPS project, and this is quite important because my experience is that intervening early is very important. Also perhaps to prevent some of the resignation or hopelessness expressing themselves as a lack of desire to work that you often see in older patients. So the whole idea is to start early to try and prevent some of that. And I just put out a paper about that where we show that early detection and intervention in itself also prevents vocational dropout. Now this is without the IPS methodologies. So we thought, what can we do if we combine early intervention with a structured psychosocial intervention such as IPS? So this talk will be very practical, out of respect for you guys having been to a long conference, and it's the Saturday last talk. So it's about our experience in trying to integrate supported employment with supported education. also our experience is trying out this new scale that Jaap has shown us earlier. Where are we? We are from Norway and from Stavanger, the southwest oil town. As you know, we are going through quite a bit of an economic recession almost because of dropping oil prices. But traditionally, Stavanger was a very wealthy town. This is our team working with school, both supported education and supported employment. And this is my partner in crime, Lena Heitmann. We started Job Prescription 10 years ago because we were working at an outpatient clinic helping young people with emerging psychosis or first episode, and we were frustrated. These guys, they were put on benefits almost per definition, almost like, okay, so you have schizophrenia, let's cancel everything. Why don't you just sit still, don't rock the boat, and avoid all stress for the rest of your life? We thought that was unfair. We thought it was an injustice. So out of idealism, we started Job Prescription, which has now also evolved into supported education in school prescription. So what's the background of these teams? They are made up of social workers, psychiatric nurses, that's specialist nurses with extra training. Most of them have experience working with schools, as we are connected to the TIPS program, the TIPS project, which is the Scandinavian Early Detection program. And a lot of the work in TIPS is about information and awareness campaigns at schools. So many of these people have experiences working with schools. But it's also a lot of learning by doing, as this is a new field we're moving into. But we hope that the knowledge dispersion across the team will happen in the way that it started out as we have a team of, we had a team of 8 workers doing supported employment. We added 2 more people who were specializing in supported education, but would see an increasing integration of the 2 because some students want to try to work. They're tired of school. Let me try some work. Maybe go back to education after that, or vice versa. Some people are in education and think, you know, this study isn't for me. I need maybe some time to try some work at somewhere else for a while and maybe back again. So the flexibility of the transitions between earning, learning, and maybe back again is important. And as a team as a whole tries to follow that whole trajectory through, from earning to learning, back to earning. The population that we serve. Of course, Norway is a country with quite few inhabitants. So I checked with the Bureau of Statistics and I saw that our catchment area is about 340,000 people living in the area that we serve. The age group that we are mainly serving is between 13 and 30 years of age, and there's almost 10,000 of them, 8,973 as of the day before yesterday. Secondary high school, I'm not sure what it's called, but in our system it's a secondary high school, 16 to 18 years, 16,000 pupils. Of those, about 3,200 will drop out of school with no education finalized. They will drop out before they do their exams, which has consequences, as Owen was talking about. And of those, 928 will do so because of mental health issues, mental health problems, personal issues. So how many can we help? Not enough, unfortunately. Acquiring a good fidelity, according to the IPS method, requires us not to have more than 20 cases per person. So we try to adhere to that. So since the start of this supported education part of our project in 2014, we've had 67 students. 23 of them have treatment in child and adolescent mental health services, meaning they are quite young. They are under the age of 18. Of those 67 students that we are helping or have helped. 27 are now finished the program, 16 of whom went to full-time ordinary education. 7 people did not feel ready. Of course, this happens also. It's not for them, not now. We try again later. 1 had to try a special education facility, because our whole point is trying to avoid that, try to avoid taking the kids out of an ordinary school setting and into a special education facility. So the whole point is normal school, right? So 1 of them didn't work. We have to be realistic. Sometimes that happens. And 3 people moved out of our catchment area. So as I was saying, school prescription is in a way a spin-off of job prescription. And why is that? Beside the transitions between earning and learning and perhaps back again, it's also our patients got younger and younger. Many are still in school. We are serving kids down to the age of 13. And also we see that many educations have school-organized apprenticeships or internships as a part of the education. What should you offer then? IPS for employment or for education? I don't know. I think we should do a little bit of both and try and integrate them. Our participants are mainly between 13 and 25, some of them up to 30, people who have tried to study, become ill, have stopped studying, and maybe after a couple of years say, gee, I really would like to finish my school. The people that we have been serving up until now, but that will change probably, have severe mental illness. We are talking about psychotic disorders, we're talking about bipolar affective disorders. We're also talking about dual diagnosis, kids using substances or having used substances, struggled with addiction. And of course the focus on ultra-high risk that we have seen throughout the whole field has also lowered the age group that we are serving. They are younger. Our location is at the mental health care services. That can also change. I'm in favor of trying to move out of our facility and out into the community. But as for now, we are located within the mental health care specialist, mental health care, at an outpatient clinic. Very important to us is that our program is integrated with the rest of mental health care. So we are trying to close the gap between education and mental health treatment. So we do psychosocial interventions, therapy at the schools. Most of the kids, especially the younger kids, they struggle with some form of social anxiety, in addition to maybe their main diagnosis. And for social anxiety, it's much more efficient, we know this from research, to practice to tackle the fear outside where you are living or studying than going to the office to your therapist. So we do that out at the schools. We try to make it an integral part of the treatment, collaborating closely with the treating clinician. So say the psychiatrist or the psychologist who is the main therapist of the patient and the IPS worker will collaborate closely with each other to try and help the patient as good as we can. Also for supported education, even more focus needs to be placed on support of the support system around the patient, because these are often very young kids. They live with their parents. Therefore, parents should be involved in the support. We're talking about teachers, rest of school staff, the treating clinician, as I was saying, and the participant himself. So it's a multi-focus, multi-target intervention, and it needs to be, because for these kids to succeed, we need the whole support system around to work together. And that's something that we, in our experience, is not too difficult to do, because most of the support systems are really interested in helping this kid. What are we looking at? We have primary outcomes, of course. As Jaap was saying, this is work in progress. So I'm not going to present any spectacular data. I hope to do so later. We have also started an international group with people from Chile, from Switzerland, from Germany, from Holland, from many places in the world. And we're going to try this out, this intervention, using the fidelity scale, but we don't have any data yet. We are discussing what outcome measures would be important. Well, obviously, school and education enrollment. How many of these young patients are in school? Also, attendance. If you are enrolled, do you go to school? Do you actually show up? Academic performance, because as Jaap was saying, just to say, to count number of days in school, you could be hanging around doing nothing at school, and that wouldn't be a good performance. So something about academic performance, perhaps. I feel strongly about including something on social integration and social functioning, and also the subjective experience. Okay, now you go to school. How does it feel? Is it okay? What's your subjective experience of this? Is it helpful? Or is it just you go to school because we say that it's good for you? Because I believe that this should be, and as we work, is an integral part of clinical treatment, therapy in vivo in a way. I like to include mental health parameters also as outcome measures, such as symptoms or functional recovery. This is just a nice picture of a tool that we've made. It's in Norwegian. It's also, we have translated it to English, but it hasn't been published or anything. But what it is a collaboration plan. So it is a collaboration plan that we've made for the teacher, the parent, the participant to sit down together and fill out. It's nothing new. We haven't invented the wheel. It's based on things such as, what are your warning signs? How can we tell when you need help? What can you do when you feel that stress becomes too much, when you need a timeout? All kinds of practical, detailed things. Providing, of course, that the student is okay with disclosure, which is another discussion. Most of our students are. Not maybe sharing their all intimate story with the whole class, but with the teacher, to sit down, make a very specific plan. We use this form. And it's colorful and looks nice, I think. So one of our team members made this one. I can see now that it is actually the English version I have here. Okay, thanks. So, of course, these slides will be available. If anybody is interested, this is not, I'm not in it for profit. Everybody can have it, see it, get it from me. So we've tried it out. We are at the start of our project. We have been working like this for 2 years, but the fidelity scale was just drafted. So we have had an external rated who was certified in IPS rating for employment. But as we haven't done this before with education, of course she wasn't certified as that. She's really friendly, but she was strict as hell. I tried to bribe her, offer her money, but still the scores were not excellent. As Jaap was saying, most of the items of this integrated scale were applicable both to employment and education. It's also, when you score the fidelity scale, it's important to bear in mind that you're scoring the team, not the individual client. So you're scoring one score for how well does this team perform on employment and how well does this team perform on education. So sometimes there are differences in the items that needed attention. And therefore, we landed on having 2 scoring columns. There were some differences, and the team could perform differently for education versus employment. Therefore, we have 2 scoring columns. However, the end scores are compatible, so you can compare it. So both scales, both the SE employment part and the education part, have a maximum score of 125. But it was important to make some adaptations. I won't repeat too much of what Jaap was saying, but things like medical insurance, medicine reimbursement, rent, housing benefits, survivors. It's a lot of things that weren't really applicable to our 13, 14-year-olds, so we changed a bit of the wording there. So that now our support is quite specific in some items, such as support in enrollment, financial income needs, books and study materials, transportation, class schedule management, study skills assessment. It's all things that are not so applicable if you're looking for work, but very relevant for kids going to school. So we did get different scores for the employment versus education part. And as opposed to Holland, we did better for the education part, actually. We only got a slim, fair score for the supported employment. And why is that? We have too much use of internships, unpaid internships, where people keep their benefits and try out different jobs. And I tend to go on doing that because for me that's about career development. People need to have the chance to try out different forms of careers before making a choice. And it's not for years, it's a couple of months, right? And then we, of course, make transition into paid employment, but we do often start with internships, and there's a lot of debate about that, but that's how we do it. Also in the future, I think I started in my talk to say that we serve people who have severe mental illness. I'm now launching a project that I hope I'll get funding for, to have kind of a outpatient service at schools. And of course, that would be free from diagnostic boundaries. Anyone who was struggling with mental issues would come and could get specialist mental health care combined with accommodation of the education based on the expertise that we do have. I do believe we have more expertise on the specific issues of mental health problems and how they relate to education, so that we have something to offer, but we need to get out of our offices and out there. It's important for me that we tear down the barriers between education and health services. I think we can do better than we do now. Also, I'd like to talk to the school staff. What do you think? What do you need? How can we assist you in helping these kids that are struggling? And also, when we're done, I'd like, as a secondary outcome measure, to interview school staff. What did you think of our intervention? How can we improve? How can it be better? I pushed the wrong button. Oh, thank God. But anyway, thank you for your attention.
Any questions? Yes.
Hi, that was really interesting. Thank you very much. I work in Ireland, and one problem we have is this barrier, this gap between child and adolescent services and adult mental health services. If you're based in an outpatient setting, how are you managing that transition gap?
There's a couple of things I could say about that. I'll start with the most important one. We are lucky to have a department that's called the Department for Young People, which actually goes from 15 to 30. That's a department. But also we have the child and adolescent mental health care services. Until recently, we were one psychiatric clinic. Now they split them, but I do believe that the transition, it's all about collaboration and communication. And so I don't have a very exact answer to it, other than making sure that you're closely connected to the child and adolescent mental health care, so that you go there, visit them, get to know people. I think a lot of these projects are very much about the human factor, you know. So that's how we do it. We try to keep in touch with the people, and we have this young people's department, which is just basically lucky for us. Yes.
Any other questions? Okay, thank you. Thank you. Okay, thank you, Venki, for that wonderful presentation. And again, kind of exciting stuff that we're doing. Let's see if I can now figure out, oh, I need slides. Oh, there we go, okay. So good afternoon, and again, I'm so happy that you guys are here. It's great to be here and be a part of this conference. And thank you for staying at the last of the last day, so I appreciate that. My name is Luana Turner, and I'm a clinical psychologist and research psychologist at the UCLA Aftercare Research Program, which is, okay, I'm short, so I have to, which is a clinical research program where we work with first episode folks, and that we're helping early on in the course of their illness. And I also have a lot of experience with the IPS model. It's very near and dear to my heart, as you'll see here. So I think that change is kind of a mixed bag for all of us, and this is one of my favorite quotes, actually, by Socrates, where he says, the secret of change is actually to focus all of your energy not on the fighting the old, but on building the new, which I think is really important, and I think that's why we're all here at this conference, and it's what we're trying to do. So I'm going to talk today a little bit about the beginning of IPS, the beginning of fidelity, the beginning of supported education in the theme of the conference, and then kind of catch us up quickly to where we are, but I'm going to make it hopefully interactive and fun. So as I like to say, in its infancy, I was one of the fortunate people that went to Dartmouth and got trained early on with a small group of other people. The working life for people with severe mental illness, had just come out. It was actually just a stack of papers. And there really wasn't a fidelity scale. That was a stack of papers too, which I still have in my office. And I was really excited and went and met with Deborah Becker and Bob Drake and spent some time over there. And then I came back and I was in graduate school and I was super excited to start this work. And then what happened was I went out and my client said, well, I want to go to school. So then, of course, I came back to Keith Nectarline, our director and PI, and Debbie and Bob and said, well, now what do I do? And so they, said, well, adapt it. And, kind of figure out how to do that, and let's take copious notes and let's see what we come up with. And while that was very exciting, and I was really excited as a graduate student to be part of this new movement, it was a little scary. And I love being a student. I would be a student till the day I die if you let me. And I figured, okay, I have some ideas about how to do supported education, but I really, didn't know what the formula was. And so I quickly did a bunch of research and found Karen Vianger, who had a wonderful book, the Handbook on Supported Education. And so quickly I had these two Bibles. One was Bob and Debbie's book and one was Karen's book, and put together all of these subtleties that you guys are going to see on our integrated scale that Jaap and Venki showed you guys a bit of. And then Keith and myself and Bob and Debbie and a couple colleagues, Kenneth Subotnick and Joseph Ventura, wrote our paper in 2008. And we actually had really, really good outcomes. Because it's the end of the day, I didn't put a bunch of slides up about outcomes. It's an old paper, and it's easy to get. I can send it to you. But basically, the idea was that we found, because I trained on the IPS model from supported employment, but then I had to learn supported education, I didn't know any other way. It was an integrated model from the beginning. Our biggest struggle was helping people to kind of pick things gradually and not try to go from 0 to 100, which is often what happens with our group, and helping them to maintain their goals. And then, of course, like all people, we had to get fidelity reviews, and we got dinged on our fidelity reviews. And I said, wait, that's not fair. We don't have supported education. And so my friend Jaap, I contacted him, and he connected me with the folks at the University of Kansas who had this nice initial supported education scale. And so we used that, and Bob and Debbie gave me a little pass, but, we got better, and we continued, despite there not being an integrated fidelity scale for IPS at the time, to integrate the model. And in fact, as we hired people and the model developed further, we hired people with the idea that they needed to know something about these two separate pieces of interventions and then train them based on how I trained myself, kind of, and went forward with it. And we actually had some really wonderful outcomes. But as Jaap was saying, it's not easy. I think the hardest thing is to think about change, and it's hard for us to let go of the old. It really is. And I think that when the idea of supported education started, supported employment started, people were not completely on board with that in the place and train model, And so the idea of integrating supported education, I just hope people will have an open mind as we move forward. And so kind of to catch you up in the theme of the conference, now Karen has actually a supported education evidence-based practice toolkit, which you can get on SAMHSA, and she also has an updated version of the supported education handbook, which is really wonderful as well. And our friends at University of Kansas also have a toolkit, and this is a wonderful theme that I think you guys saw if you went to PepNet and saw different speakers, that, us coming together and making these resources like Venki's group available to everybody, and it's going to really make a difference in helping people and changing outcomes. And so what happened was, back when I was doing IPS and I was in graduate school, and then later I met Owen, and he started kind of saying, and Bob and Debbie had been saying, Luana, you need to do a scale. Why don't you create a scale? But things happen and life gets busy, and Shirley Glenn will like this. I always thought of myself as more of a clinician than a researcher, even though she always said I was a researcher too. So I was a little nervous and felt insecure about trying to do a project like that, but thankfully, Owen kept on me. And then Bob and Gary did this special edition paper that was very inspiring to me, where they talked about, at that time, there was 20 sites that had, implemented the IPS model and had great fidelity. And we're talking about several different continents, a range of, different problems that people were struggling with, and it just was very inspiring to me. So I said, okay, we got to get going with this. And as Owen showed in his slide, I went to iFever, iFizz, and made a pledge, because you always have to make a pledge at iFever, iFizz about what you're going to do. And so the pledge was I was going to go there, talk about the scale, which I had kind of been keeping notes over the years and had a lot of ideas about how to change it, but hadn't really shared it with anybody. And that's when I met my colleague Venki, and then we got Jaap and Owen and Miles Rinaldi involved, and so that was very exciting. So of course, as soon as we decided to do this project, I called Bob, Debbie, and Gary Bond, and Gary shared with me that Marsha Ellison and he and a group was doing something really exciting with some young folks over at Thresholds in Chicago, residential treatment. It was kind of a specific population with African Americans aged 17 to 20 that were a custody of the state. And what they did was, what we had in mind all along was to take the scale and integrate it and have a subscale of supported ed, a subscale of supported employment, and then an integrated scale at the end. And what they did in adapting the scale further was they added peer mentoring component, which is also another wonderful intervention, and also some supported education components about accommodations, enrollment, and specific supports. The big one, which Venki it's very near and dear to her heart, is the career development piece, which is something that we always did at UCLA. So it's this idea, and our population there is 18 to 40. So when I think of this, you guys, I think of this model as not just for young folks or first step. I think of it also for older people or people who want to go back to school, or they have the career that they wanted to focus on, but, they were dealing with mental health issues, and now they actually can do that. So this is not a first step only model, and I'm not thinking that way. And in line with the IPS model, I think it's an integration of all populations that need help. So basically, what what Ellison, Marcia, and Gary and everybody found was they did fidelity in 2011 and fidelity in 2012. So typically it's kind of standard to do fidelity reviews once a year. And like everybody, you know, they got some, you know, feedback about ways they needed to improve in that first year. And I think, you know, David Fowler and many other people in the conference this week have been talking about how you need time. And that's something that policymakers, and I think David McCade too also, there's something about policymakers that they don't get that. But of course what then ended up happening was in 2012, their fidelity improved and they all achieved high fidelity except for the 2011 supported education group. And I believe that, you know, what they said was that they had to go out, much like what Yap was talking about, and get a specialized person to do supported education because they didn't know a lot about that. And I think that it's all has to do with the training. Now, I have a unique experience because I've been an IPS worker, a consultant, a trainer, and a fidelity reviewer, and I was trained at the at the beginning, inception of the IPS model, to do work and school together. So I admit I have a bias. But I think from the people that I've worked with and trained to do this, that it's possible. And that's what we're looking at. And so, you know, as Venki was showing in Yap, that we have this model that is integrative. We think it's flexible and it meets clients where they are. I think we know that the IPS model works really well, and it's been researched, it's an evidence-based practice, and we know that supported education is a very important intervention, not just, you know, as helping people to move forward in career development, but also in the recovery, you know, of their lives if they've had setbacks regarding what they would like to do. And then as Owen was talking about, the kind of the field of employment is really shifting, and I think that we haven't really done our clients a service when we probably buy into thinking that they can't go to school or they can't do certain things. I mean, I'll tell you right now, on my caseload at UCLA, I have 2 patients that were catatonic and completely psychotic, and they are both in medical school now. So that's just my selling point to say that with time and the right supports, it can be done. This is, you know, an exciting period, and I think that, as Venki was pointing out, we really want to know, how do clients feel about this? So we're planning on having a survey and finding out. Now at UCLA, something we've always done is, you know, ask like, what's working? What do you like that we're doing? What doesn't fit? What do you hate? And what would you like to see us do in the future? That's something we do all throughout our work with our clients. We're very transparent, and it's really powerful because they give us great feedback. And so we're going to be doing that in our upcoming next 2 years as we're collecting all this data. And we also think it's important to understand how the IPS workers are feeling about doing this work and the supervisors. So we're going to be getting a lot of data. So my hope is we'll be able to organize it all enough to give you guys some good stuff in 2 years. But we're going to have a lot. And we also want to understand about strategies. It's important to understand what clients use. So for example, one thing I noticed in working with First Step at our program, and this has been happening for 17 years that I've been there, is people will be on the hospital unit and they'll say, I don't need medication, I don't need treatment, I just need to go back to work or school. Thank you. And basically, you know, what they really want is just to kind of go from 0 to 100, and they haven't developed strategies on how to kind of go back. And then of course, if they blow out, they erroneously think it's part of something about themselves. They think they've done something wrong, when actually it's their strategy and the way they've gone about it. And Roy and their group actually pointed out some strategies that they found that clients were using with supported education. In the First Step group, in comparison with the control group, was actually so focused on education that it was at the expense of social, leisure, and work. But yet they were totally focused on motivation and getting through school. And I know that we need to do a better job of helping our clients to balance out things. And that's something that we do at UCLA, so I'm hoping to be able to consult with our groups on that. So briefly, I'll just say that although our team is wonderful and we've had a great time these last 2 years, they made me promise that I would talk a little bit about some of the challenges. And so, you know, we have Australia, England, the Netherlands, Norway, and the US. So as you can imagine, some of us were having coffee, and often Venki and I spoke a lot on Skype, and I would be there with coffee, and she would be there with her glass of wine going, what? So, there are definitely challenges. I want you to know, I didn't put up, I don't have any conflicts of interest, but we got no funding on this. And I think for many of the people in this room, you know that when something's near and dear to your heart, you just do the work. And so there was no funding. This is all with dedication. We had no time to do our daily stuff, let alone commit to this, but we all did. So if you're feeling a little less inspiration about a project you're working on, I just want you to know that it's doable. Don't give up, because as you move forward and see the goals and come to fruition, it's amazing. I was told that this project that I had at inception was way too ambitious. And so I'm just happy to say that when people tell me that, I just kind of move forward, and our group has done this. And it's been an amazing collaboration. This gives you a sense of all the people involved in our groups. And so one thing I just want to say is that I hope, let me go back, in 2 years, when I show this picture, I'm going to have to make these really, really small, because now, as Venki was saying, we had a big meeting last night, and we've got all these new groups that want to test our scale out. So I'm super excited. We have Chile, we have Germany, we have Denmark, we have a bunch in the US. And we had a great meeting last night. And at iFever, iFizz, for any of you who go, know that you always have to make a pledge. So we've already met our first pledge, which is we have 10 or 12 new groups that are going to try this out over the next 2 years. So it's really exciting. Now, we do need, as you heard from Venki and Yap, to have it tested for a longer duration, because you need time to show change. And so we're also going to do surveys with the clients. We'll be doing fidelity reviews once a year and assessing outcomes. And I just want you to know that even though this is near and dear to my heart, and I'm a little biased that I hope it'll work, I definitely want to know what our challenges and what changes need to happen. And these are the thank yous. I just want to say thank you, because without Bob and Debbie, there would be no IPS model. And Miles, who couldn't be here, also an integral part of our team, Gary Bond, a wonderful consultant, our team, Yap and Venki's staff, IEPA, and definitely Anna and her group. Thank you all very much for your time. Do you have any questions? Yes, Doug.
You mentioned, thanks. Is that on? Yep.
Yeah.
You mentioned using peer mentors. I wondered if you could talk about their role and what they do. Is that sort of helping to sort of motivate people and get them moving towards education? Is that tutoring, study skills?
I'm sorry, and it's probably the way I presented things, so I apologize. We don't have peer mentors in our study right now, because basically what we're focused on is the fidelity scale and trying this out, and we're going to have a lot of different sites. Now, some sites might have peer mentors, but I think what you're thinking about is when I was referring to Marcia Ellison's study with Gary Bond, they took the scale and adapted it and added a peer mentoring component. So if you don't have that paper, I can send it to you, because it's really I actually think I have it with me. It's actually really wonderful, and they did add a specific component, so it would be good if you wanted to talk to Gary and Marcia about that. It may be the case that some of our sites, because we have all these new people that are going to be involved, might have peer mentors. We don't know yet, because we're just in the beginning, but that's not an actual component as of yet on our fidelity scale. We're just doing the integration of supported education into the original 25 items of the IPS fidelity scale. Thank you, though.
Yeah.
Thank you. Any other questions? Oh. Okay, you guys think? Oh,
People still alive?
yeah, I know.
Do you want to say thank you?
Oh, yeah, I want to thank you all. I was just amazed at how many people showed up today and actually stayed, because I know it's the end of the day, the end of the conference, and there's so many competing great talks on right now that I actually wanted to go to as well. So I just want to thank you all for your attention and your time. If you have any questions, and to my colleagues in the room that are on board with the scale, thank you so much. We're super excited, and in 2 years, we'll have lots of stuff to share with you all. Thank you.